Good evening, everyone, and welcome to the 21st monthly webinar. My name is Danish. I'm a product specialist at Collective Minds. This evening, we'll be doing something a little different, which I've been very much looking forward to. We've got a special guest, Dr. Joekes from Worldwide Radiology, who will be delving into the topic of infectious diseases alongside Dr. Imran Lasker and sharing a few cases from other regions of the world, such as Africa. So very much looking forward to that. You should now all have access to the Collective Minds platform. And when you first log in, you will come to the homepage, which is the global community. So this is sort of a free professional network for medical imaging. We have just under 19,000 radiology professionals on the platform with just under 4,000 cases, which can be filtered via subspecialty, hashtags, and activity. We have also put the cases from tonight's webinar onto the global community and arranged them into a collection, which is just a playlist of cases for presenting. I'll be sharing that link to that collection in the chat now, so you will be able to get access to the cases and follow along during this evening's webinar. If you do have any issues with getting onto the platform, do let me know in the chat box, or you can email support@cmrad.com and someone will be able to assist you. I'll also be sending you a short feedback form at the end of this webinar, just to get some feedback from you guys on future webinars, what you would like to see, so we can continue providing you with good content and value. So once you have filled in that feedback, only then will you receive your CPD certificate. So please do fill that in at the end. So I'm just going to send the link to the collection now. So please do access that there. And with no further ado, I'll pass you over to Imran.
So, hi everyone. I hope everyone is well. My name is Dr. Lasker. I'm a consultant radiologist, slightly different place from where I usually am. I got stuck in traffic, had to park at a car park and do this one. I'm really, really sorry. But I'm really excited about this one. We are doing a bit of a collaboration, having a very, very special guest with us, Dr. Elizabeth Joekes. For those that don't know, she trained in interventional radiology, moved from Ghana for 3 years of work as head of radiology of COMFO and Noki Teaching Hospital, and has a real passion for radiology and global health and exploring the understanding and the role of medical imaging and low-resource healthcare systems ever since. And in 2017, she actually co-founded Worldwide Radiology in the UK to create a community of imaging experts who share this interest and passion. So it's a really, really great cause. It's a really, really great way to promote this cause. And actually, we all get to learn from some of her experiences and stuff. So it'd be really great to introduce Dr. Elizabeth Joekes, who will now go through some really good cases. Actually, I've had a good flick through, and I'm excited about tonight. It's going to be very collaborative. So obviously, as usual, ask as many questions as you want. And since I'm the one on camera, I get the liberty of actually asking a few questions as well. So without much further ado, please, Dr. Joekes, just please go ahead and introduce yourself. And I'm really excited. Let's go for it.
Great, thank you. Thank you very much. So thanks to you guys for inviting me. We've been working with Collective Minds for a while now to get images from various partner sites that we're working at across for people to share images, like, you know, from the Gambia, for example, with people from the UK and people from Singapore looking at images from Malawi. So it's been really great collaboration that we've got. What I wanted to do really is to show I'm not a chest radiologist, and I know it's maybe a tall order to start looking at chest X-rays at 6 o'clock in the evening or wherever you are. But there's such a workhorse still for so many places in the world, and sometimes I think we sort of don't really think about how great chest X-rays still are because we think about all these other, you know, super fancy modalities. So the cases are a mixture. Some of them are from here. I'm based in Liverpool. So I've done infectious diseases, tropical medicine, radiology here. I'm linked with the School of Tropical Medicine. And so I've got a collection of cases from across a couple of our sites, plus from here. And we'll just go through those and see what you all think about them. Imran's going to keep an eye on the chat if you've got questions. So I've got to start by sharing my screen. That will be there. There we go. So hopefully you are now seeing my screen, but I don't think you are you?
Yeah, we can see your screen.
You are,
Can see
great,
it.
brilliant. Okay. So I think I'll just start with the first one. Imagine yourself, so I'm going to give you a little bit of scenario. So yeah, it's 6 o'clock, you've had a long, hard day, you've got 20 x-rays, chest x-rays to get through. So you're basically wanting to get home. And this is in your pile here in Liverpool. And all the information you get from a GP is that this is a man in his 40s, and he's not feeling great. He's not really coughing, just general malaise. And this is the x-ray that we come up with. So have a look at that and have a think about what you think this might be, how you would like to report this. I'll give you a little bit of time. Is that right, Imran? So that people can digest it. And I don't know if Imran, if you've had some ideas while you were looking at this, or
Yeah. I mean, I usually try and talk through it. Yeah, and I think I mean, I just have to put a caveat that I'm not an expert in chest imaging, but I do a fair bit of plain X-rays, like you say, is a workhorse. It really is. I mean, it's the initial investigation for most situations that can arise. So this is a very, very important thing
yeah,
um, that we have. So I think on this one, I don't know what everyone else thinks, but you kind of just look at your costophrenic angles, look at behind the heart. I can't see anything grossly abnormal, but it's that kind of mid to peripheral zones of both lungs. They look a bit hazy, and potentially even a small cavity potentially located with the right mid zone. So that doesn't look quite right. And
yeah,
that right hilum to me looks a bit enlarged. So I'm worried that there could be a bit of lymphadenopathy sitting within that area over there. I think the rest of the mediastinum looks okay, and the upper abdominal organs look all right, and I can't see anything skeletal going on. So there's definitely something going on bilaterally. And with the lymphadenopathy, I've seen a few people say a few things, and sarcoid wouldn't be a bad shout, considering you've got what looks like upper lobe opacifications and some lymphadenopathy. What else? Other people are saying bronchiectasis and cystic space in
yeah,
the mid-lung zones. Yeah, I think mid-lung zones, there's definitely something going on. Someone's gone for TB. I think it's probably based on your background and your interests as to why they've thrown TB in. Certainly could be, especially with the what potentially could be a cavity there.
great.
Uh,
Wow. So you're doing
yeah, let's
the
see.
work for me, Imran. Yeah.
Yeah,
Yeah.
trying my best, but no, carry
No,
on. You tell me.
that's really great. And while you were talking, I wanted to give people a chance to sort of see what they were going to come up with, and I've seen some really good stuff, as you say as well. We've got these lovely fading arrows now, so I think most people have noticed this area up here. You can see it's a sort of irregular opacification, maybe a little cavity potentially. There is mention of some cuffing of the larger airways, and you really rightly mentioned that there is actually also an abnormality here at the left. So this makes it a bilateral upper lobe, ill-defined sort of parenchymal abnormalities. The right hilum, yeah, you could. I think that's a little bit sort of up for discussion. You can still see it's concave in here. You've beautifully described the rest of the film, so I don't think we need to worry too much. The paratracheal stripe here is lovely and normal. If you've got bilateral upper zone abnormalities and you are worried about TB, then that's an area that you really want to investigate, don't you, properly? No lymph nodes there. Normal costophrenic angles, as you said. So I think sarcoid is a possibility, but I'm not entirely convinced about the lymphadenopathy. With the general malaise, the bilateral upper zones, I think that the TB is at least something that you shouldn't forget to put in your differential. And to be fair, that's actually why I put this film up, because in the rush of a 6 p.m. I need to get home reporting session, this film was actually reported as normal. That's why I put it in here, because I think it's a really important thing. Most people, when I use it, this film, pick up the right bit, sort of don't always pick up the left. So here, when you see upper zone abnormalities in a patient who's young enough that it's less likely to be cancer but possibly infective, you might say, okay, right upper lobe, a bit of inflammatory change. always make sure that it's not bilateral, which you picked up on beautifully. So definitely TB needs to be in your differential. I think that is my key message for this case. And if you then think that that is what it is, the differential could be that it is just some bacterial infection of other causes. It's a GP patient in Liverpool. You'd be justified to say, okay, the GP gives some antibiotics, and then, but you would really have to recommend a follow-up film here, wouldn't you? You would want to make sure that these abnormalities go away. Somebody's put a question, are they immunocompromised? I didn't get the full history. No, you didn't get the full history because this is a GP film. So I did that deliberately because I don't know, but in most places you won't get a full history, do you? You just get, if you're lucky, you get general malaise, shortness of breath, and that's about it. And you raise a really good point that to do this well, we need much more history than we often get. No, this is not an immunocompromised patient. So the short answer is they're not immunocompromised. No. So is there anything else you might want to think to help you? What are other sort of risk factors for it to be TB if they're not immunocompromised? Exactly. Occupation, travel abroad, absolutely all true. So this was actually a migrant worker from Eastern Europe. And now that I tell you that, then again, TB goes further off in your differential, doesn't it? So we now know this is a migrant worker. They travel to endemic areas. He's a prisoner, exactly. Refugee status. Yeah, exactly. All those things are risk factors. And I think, in that case, I think I would flag up TB as a risk right from the start. So everybody in this group has already done a lot better than what happened in real life. In Denmark, you often see it among alcoholics. Yeah, homeless people here is a big group. So yeah, I think we've nailed it really. That if you only see the unilateral abnormality, at least make sure you always ask for a repeat film because it's atypical. It's not your bog standard pneumonia in a 30-year-old where you might not want to follow up. It's in a bit of an unusual place. It looks a bit odd. If you say do antibiotics, do a 4 to 6 weeks follow-up. But you've picked up bilateral, you said TB, so I think actually you've already set the train in motion. So I think unless people have other things, I think we could move to the next case. Is that, you got anything to add, Imran, or ask, or?
No, that's an interesting case. I mean, I can imagine being in a bit of a rush and just not really, yeah, it does happen, doesn't it? Unfortunately, when you've got 100 X-rays to do in a short amount of time. But
Yeah.
I mean, I assume the next case is a follow-up, isn't it? Is that right? Have I got that right? The next one, or have you got the follow-up?
So yeah. So well, the next case exactly. This isn't. I need to put that in the viewer for you. So I'm new to this webinar model. I just need to find my way through it a bit. Yeah, so you're absolutely right. This is the same patient who came back 9 months later. He went back to his GP and said, look, I'm feeling increasingly rotten, because he had this report of a normal chest X-ray. Went away, struggled on. And 9 months later, the GP, he's much worse. He's coughing, he's really not well. And this is how he presented. And this is when it was actually picked up. So maybe take a bit of time just to scrutinize that film. And then do you want to do the poll maybe? Yeah, so which of the following would you do if you're reporting this? And you can choose multiple options.
Just out of interest, Liz, when you open this X-ray, the follow-up, has he fractured something the clavicle in the meantime? Have I got that wrong? I'm just looking at your screen. I'm trying to open it on my.
Yes, the MSK radiologist.
It does look dodgy, doesn't it? It looks
broke. Yeah, was it
abnormal.
not broken on the previous?
Let's have a look.
Oh, okay. Let's go back to the previous. Why not? Oh, can I go back to the previous?
Yeah, you should be able to go back and open it.
I should be able to go back.
Just go back. Yeah, that's it.
There we go. Yeah, you're right. Well spotted.
Hmm.
Yeah.
Yeah, MSK.
Yeah. MSK. So he's had a
There we
rough
go.
time in the meantime. Yeah.
Yeah. Oh dear.
Nice one. This is okay. So now I need to go back to case number B. Here we go. Open. So meanwhile, have we got some answers to this poll, or have you opened it?
There we go. Yeah.
Okay, great. Yeah. So we've got miliary TB. So one of the responses, people saying miliary TB, call the TB nurses to take a sputum sample and start contact tracing. Yep, absolutely. Disseminated versus co-workers pneumoconiosis. Disseminated active TB. Yeah, lots of good responses. Yeah, so antibiotics in a 4 to 6 week follow-up film, 24%. Alert, 44%. 80% would arrange for a copy of the report to be sent to local TB services. So in the UK, for the UK audience, that is actually nice guidance. And I think even in our hospital, I couldn't really manage to make that happen. It was really complex. But nice guidance is that if you, on imaging, think you're seeing active TB, that you should alert the TB services. So whoever was going to call them, that's really helpful. You pick up the phone and say, I've got a patient here, you need to isolate and sort out and start contact tracing. This is exactly, so if we look at the appearances, important for infection tracing, exactly that, because in this case, the contact tracing activity, I think they had to trace, it was really hard because he had been back to Eastern Europe in the interim. So they had to liaise the local service with the Romanian, or I think it was Romanian services. It's a complete nightmare to do contact tracing on this case, which is why, again, it's here. Lose it at the first opportunity. This is what happens. And here, I think you can see, so this is not miliary TB. Miliary TB would be this very fine, widespread, disseminated, diffuse nodularity, whereas here you can see there are some cavities. This is all endobronchial spread. You've got these sort of little fluffy consolidations, sort of, little confluent areas of consolidation, and a huge amount of endobronchial spread. It's now, from those two patches, really gone throughout both upper lobes. Not a lot of lymphadenopathy. This is really widespread active TB. You can see that cavity there. I think it's got cavity up there. So yeah, this is a really, sad case of where it was missed. And anyway, he got better. You'll be glad to hear. And it wasn't multi-drug resistant either. So I don't know if people want a bit more about the actual findings on the film or whether we will move on to the next case. I think co-workers pneumoconiosis was one thing I'd see here, Rashid. It would be a bit odd that he developed it that quick and that widespread. I think that would be, will have a longer history, more dense consolidation abnormalities in the upper zones, but it's something to definitely consider in patients who work in an area where a lot of coal mining happens and where TB is endemic. You can get combinations of it. Please describe the X-ray. Okay, so we start with, depends how everybody has their system, but the quality of the X-ray, it's good inspiration, it's reasonably straight, it's a PA film. So I always try and get rid of the stuff that is not the main problem first. So I see lots of abnormalities in the lung. I might think, well, let's first just do away with all the things that are not abnormal, including the clavicle, which is. So looking at the bones, the ribs, we've done that. There's a clavicular old fracture, but nothing else there. Then I will look at mediastinum. So again, I'll look at the paratracheal stripe here, which is normal. So I'm not seeing adenopathy there. I can see the aortic arch here, and I can see the contour of the aorta coming all the way down here. The heart size is normal. The outline of the heart, I can see it. The hyla here are difficult. Hyla are often difficult. And here you've got all this opacification overlying the right hilum. So it's going to be very difficult to know whether there is any adenopathy. I mean, it's not very dense, it's not very nodular, but the hyla are quite difficult. Costophrenic angles are clear, I'm not seeing effusions. Then I'm going to focus on the lung parenchyma, which is what it's about here. And again, distribution of abnormality. So it's both bilateral upper zones and then mid and lower zone on the right. Describing the lung changes is difficult here. I would say there are patchy confluent areas of consolidation. There's endobronchial sort of almost where you, if you imagine the CT scan, it would be, you know, tree and bud changes. The cavity here that I described, it is bronchopneumonia. So it's sort of patchy, distributed bronchial wall thickening. There's probably some bronchiectasis here as well, with bronchial wall thickening here. So very widespread bronchopneumonia changes in focus on the upper zones. I hope that. So do we ever get a CT? That depends entirely on what you've got available. I mean, in many of the places that these films come from, there is no CT. In this case, I don't think it's necessary. I think you've got your diagnosis, you need your sputum test. Maybe on the previous, I think even on the previous, I would have referred to the TB services. But if you're in doubt, and then a low dose unenhanced CT can be really valuable. Yeah. Great. So that was that one. Then we'll go back to the collection. And while we're on the topic, here is another case. And I'll give you all a chance just to think about this film and see what you think about it. I want to use the pencil tool. Thank you very much. Yeah, I will. Let me put the pencil tool there. Okay, yeah. Yeah, so what do people think about this film? Quality of the film, acceptable or not?
Looks like a photo of an X-ray, doesn't it?
It is, but this is what the original film looked like. I mean, this is it's a hard copy, so it's not a digital film. It was a hard copy. You can see on the edge the marker. It's one of my older collection. But basically, I think the point here for me was to show that you can get films of which we might think the quality is not ideal, but even if the quality isn't ideal, it's optimal to you still have to try and make the most of, you know, using those films, because it can be very costly or difficult to repeat films. Somebody said dense consolidation, right upper lobe, mass-like opacity with cavitation, overpenetrated film, absolutely. Right upper lobe, patchy consolidation. Okay, so somebody's saying maybe inactive TB. Now, this is another topic we're going to talk about. So yes, so using the pencil, I hope you can see that there is this cavitation here, that the cavity has a sort of fluffy outline and it's embedded in what looks like an area of consolidation here. You can see there's volume loss of the right upper lobe because this is your minor fissure here. And in that upper lobe, potentially you're seeing some cavities here as well. And overall, it's quite dense, but it's not really doesn't look like a lobar pneumonia. The left lung, you can't really see, but there aren't major abnormalities, but you can't exclude minor ones. I think exactly, somebody's put active TB with old TB. I think that's definitely a possibility. Oh, there's my arrow, sorry. That some of the volume loss may be due to a previous episode of TB, and then if you get reactivation, you get all the consolidation and the cavitation with it. Sometimes in active TB, you also get volume loss. But the message here is that I think this should be considered as active TB until proven otherwise. There is too much consolidation. There's this thick-walled cavity. I would be worried to call this old just based on these appearances. And you can see a bit of pulled up, sort of bit of scarring here due to the volume loss at the top. So this is another example, but with poorer image quality, where you see active TB is, in this case, it's unilateral. And, you know, the reason I started with TB is because it's so widespread and common in places where, you know, either people are homeless or people live in poverty camps, less well-resourced. It's, you know, one of the number one, if not, I think COVID overtook it, but the number one infection in low resource healthcare settings. And it's important that we remember and know about it.
Interesting. Someone's asked about a hyperdensity located overlying the right sixth rib. Can you see just there in the middle? Is that artifact?
Yeah, I think it's got to be it's an artifact, I think. Yeah.
Okay.
Let's see if I can make it any bigger, but I think that's artifactual. Yeah. I
Okay.
can't think of anything that would be related to the cavity or the abnormality there. Yeah.
Actually, when you look closer, there are a few hyperdense dots all over the place. So it probably is just cavity artifact.
Yeah. And somebody has made a very good comment. It's the first and most common possibility if someone has worked in Asian countries. Unfortunately, you're absolutely right. Yeah. So I always do a plug for TB. Know about it, learn about it, don't forget about it. Yeah. Great. So now we shall move into a different arena. How are we for time? 6:30. Okay, I want to move on a bit. Okay, case number 3. So now we're in Malawi, and this is a patient. She's a female of about mid-30s, and she presents to the hospital with shortness of breath, weight loss, and general unwellness. Sorry, somebody's gone off topic. I'm afraid I'll stick to this case for now, Fatima. Sorry. Okay, yeah, I'm already getting stuff coming in. So what you're seeing on this film is relatively poor inspiratory effort. It's not a very deep inspiration. Pencil. And then the reason the X-ray was taken was because people were worried that she had TB. She had weight loss, she was shortness of breath. So does this look like TB? And, you know, if not, what could it be? And I think you can see here that the majority of the abnormalities are in the perihilar region, in the mid-zones of the lungs here. And it's sort of mild opacification. It's not really ground glass, but it's not very dense consolidation either. A bit denser on the right than the left. You can see here that there is some septal sort of thickening here, reticular thickening, and the periphery of the lung is spared here. All around is spared. There are no effusions, and again, not obviously lymphadenopathy. The right and left hilum are difficult to see, but there's no mediastinal adenopathy. Is the pulmonary artery a bit large? Or is that related to poor inspiration? I would say poor inspiration, yeah. Perihilar opacities, batwing pattern, PJP, yep, definitely. PCP if there is a history of AIDS, yep. So all great comments. Yes, it turned out that she was a new diagnosis of HIV. And these are classic appearances in that context where, you know, HIV is common. Somebody presents like this and you find these batwing opacities in a perihilar distribution. PCP, PJP is a good first thing to think about. And that's what she was treated for, and that's what she responded to. Somebody's asking about bone and lung metastases. Not sure I see lung metastases or bone. Imran? Are you seeing bone metastases? This is your
Uh, no, not really. I think what's probably happening here is you've got a lot of overlap between the consolidation, the lung changes and the bone behind it, which makes it look like the ribs might be slightly expanded. So, and then some of the consolidated changes have kind of coalesced to look a little bit more solid than otherwise. But because of bilateral and that kind of bat wing appearance, you probably wouldn't go down that road and go for infection rather than underlying malignancy.
Yeah. Yeah.
Yeah.
Excellent. Great. Good comments from the audience. You're all over it.
Mm.
And then another patient from a very similar setting who actually presented with quite similar symptoms. Mild cough, low-grade fever, and reduced consciousness. So again, here we've got a poll. So maybe take a moment to look at the film. And then let's do the poll first before I get to talk about it. Is that the right order, Imran? Yeah.
Yeah, can do.
Okay.
In the meantime, I guess we could take a look and see what's going on.
Are you concerned about active PTB here? So is it concerning? Yes, PTB is highly likely. It could be pulmonary tuberculosis, I'm not sure, or no, it is unlikely. So are you there? I can't vote, unfortunately. I can't
Yeah, I
influence
can't vote
the poll.
either. Yeah, I tried.
Should we have a look and see what comes up?
Yeah, how do we end the poll? I think.
And the
There
reason
we
I
go.
like the poll first is because of then we can, talk a bit about why people say that. So yeah, a number of people saying yes, TB is highly likely, yes, could be, not sure, and no. In this setting, TB is never unlikely, whatever the abnormality on the film. Yeah, I love that. Thank you for that contribution. In this case, I think we have a couple of findings that would put TB lower on the list. But yeah, absolutely. That's one of the comments I wanted to hear. That's great. So what we're seeing here is in the right upper zone, this consolidation, and it goes right out to the periphery. And I hope you can see that I should use the pencil, I've just been told. So let me try that. You can see some air bronchograms running into that consolidation there. And I think you might even be able to see a cavity here. So if I just reset that, can you
You
see?
press E, then it would erase what you've done.
Okay. I should practice harder on this, shouldn't I? I think you can see here potentially a cavity. So you've got consolidation with a cavity, with air bronchogram. And again, in an immunocompromised patient, absolutely that could be TB. It can present as a single dense consolidation. However,
Can
is
I
this?
ask,
Yes, exactly. Is
is
there
there something behind? Yeah, someone said something, but I felt like there's
yeah.
something behind the heart.
Is there something behind the heart? Excellent, because that's the tricky bit about this film.
Mm.
There is a further second dense consolidation here, a round lesion. So now you've got two rounded lesions, consolidations, one which has a cavity in it. Somebody sitting Pancoast tumor, they're generally a bit further in the apex and wouldn't be multiple then, would it? If it was a single tumor in the right apex, definitely that it could be a tumor. Tumor should be in your differential if this was your only lesion. Now that we have a second one, what are we now thinking? Lobe pneumonias? Possible, definitely. TB could do this, but it's becoming a bit unusual, a bit odd to have two dense consolidations in TB. Mycotic origin, and then somebody says unlikely. I actually think that mycotic origin is the correct answer. Because they are very rounded, one of them is cavitating, and again, in this context, remember this woman had reduced consciousness. So she's got these rounded, big, dense lesions. She's got reduced consciousness, and she's in a situation where HIV is prevalent. For me, cryptococcomas come to mind, cryptococcosis, because then you've got your cryptococcal meningitis and these lung lesions. And actually, that is what it was. So they were able on her to check the CSF, and it is uncommon to see cryptococcus if you haven't also got neurological manifestations. So this is a nice example. And again, if you're in the right context and the right setting, another differential would be pulmonary lymphoma. Potentially, they can be multiple in immunocompromised patients. So Karen, I agree with you that TB is never unlikely, but I think in this situation, we've got some other diagnoses which are a bit more likely. Yeah. Yeah, thanks for your comments on this. So unless people have some particular questions, I think I'll go on to the next one, which is case number 5A. Here we go. I'm just speeding up a bit so we get them all in. So we've come back to Liverpool, and this is again a patient who presents to a GP, only this time he's not got general malaise. He's really quite sick. He's got fever, he's really unwell, delayed presentation, not the kind of person who likes going. And these days you might not even get to a GP even if you wanted to. Mm-hmm. So what are people coming up with? Right middle lobe, possibly right lower lobe opacity, right middle lobe consolidation, excellent. Right middle lobe, because you can see fading arrows is now what I'm going to do. Getting better at this. So the right heart border is completely gone here. So middle lobe, you've got the sparing of the costophrenic angle, which also argues for middle lobe. And there's a nice sign here. I don't know if anybody sees, if you see consolidation. Oh yes, Rashid is all over this. Why do you put that, Rashid? You can see here what looks like a bulging fissure almost. Huh? This fissure looks really quite as if it's pushed up, and it's very dense consolidation. You've got a small pleural effusion with it, definitely bulging, exactly. So this is a classic example of a lobar pneumonia. The rest of the lungs are normal. This is perfectly beautiful normal hilum, no adenopathy. So now this is a GP film, and again, you know what you're going to do with this. You could just say lobar consolidation and leave it at that. But it's worth flagging up that you think this might be a Klebsiella pneumonia because they have high mortality. This is an emergency, and ideally this patient needs to be called in and be seen. They can deteriorate really quickly. Somebody's saying the right paratracheal line is bigger. I think it runs down. So pencil, the paratracheal stripe runs down here.
I think probably because it's rotated slightly, which is why it
may
look like it.
This is exactly, you're seeing this shadow here exactly, but the line along the trachea is still normal. I'll click an E and it's gone. Thank you. And here you've got, obviously, you've got urozygous vein just in this corner here. Small right effusion, yeah. So this is a classic example of a lobar pneumonia and raises suspicion of Klebsiella. Pneumococcus can do this. Other pneumonias can give you this appearance, but Klebsiella is the classic that we always think of and the one that you need to flag up. And following on from that, so this patient actually, I think he was referred, I think the GP referred him to AMU or he was called in, I can't remember. But anyway, he ended up presenting in emergency department. And he had a CT scan because I don't know quite why, maybe because he didn't respond to treatment. And we're now going to look. So unfortunately, I only have the single slice of that CT scan. But I think it gives us all that we need to talk about here. Yeah, so the bulging fissure sign, somebody said Chisoma, excellent. Normally it's described as with the upper lobe. The classic Klebsiella bulging fissure sign is when it's in the upper lobe and the fissure sort of comes down, but you can have the same. It's basically just a lobe that's really expanded. It's not respected for gravity, it's expansion of the lobe. Yeah. Necrotic lung. And why do people think it's a necrotic lung? I'll just give people some time to comment on that. No architecture, yeah. Doesn't enhance like the atelectatic lower lobe, exactly, reduced enhancement, yeah, excellent. So again, this is a case, and I'm trying to show cases where we've learned from errors, where it wasn't recognized as a necrotic lung, and there was a lot of delay in getting him to the, actually he ended up having a lobectomy, but it took a long time before that happened. He got very sick. So again, if we use the pencil, so here you've got the pleural effusion at the back, which has got a lot bigger since the x-ray. This is 4 days later. The CT was taken 4 days later. So the effusion has increased, and it's all you can see, it's loculated because you can also see it along the front here. So this is his enhancing collapsed lower lobe. And this is his very bulky, bulging, non-enhancing middle lobe. You can just about see the large vessels. You can see a few pockets of gas here. I haven't got the lung setting for you, but they were just, it was necrotic pockets. It wasn't lung, a normal lung. So this is a really consolidated, non-enhancing, massive, big, congested, dead right middle lobe. And again, that you should flag that, obviously flag that up in your report, and say, I'm worried that this lobe is necrotic and that needs prompt action and referral. And again, that can happen quickly. So unless people have questions about that one, I can go on to the next one. Imran, are you happy so far? Any comments or?
No, that's really interesting. Is what the bulging fissure is literally something I forgot for a long, long time till you mentioned it today. So I'm really glad you showed me that. That's really good.
Good,
Thank you.
good. I'm glad. Yeah, and the necrotic lung on CT. So often,
Yeah.
people so often don't think of it. We're all, I'm a general radiologist, not a chest radiologist. It's impossible to know everything. I don't see a broken clavicle, so. But it's got really, really serious consequences if you miss it, which is why I thought I'd add it here.
That's really good.
Then we've got number 6. Okay. So number 6 is a 65-year-old, and he is from the Gambia, and he has progressive dyspnea. For 2 years, he's had a non-productive cough, but other than that, he doesn't have signs of a pneumonia. His inflammatory markers are normal. Are you worried that he might have active TB?
This is there's a word come back to me. It's a gone focus.
Oh, wow.
Is that do you remember that? It was like when
Yeah.
you get TB, you end up getting these sort of, it kind of tries to sequester it and push it somewhere. That could be it. Like
A
these
gone
cyclic things could
focus
be.
is a calcified granuloma, and
Is
then
that okay?
a calcified lymph node that goes with it. So it's a sign of previous primary
Okay.
infection. So you would want to then see like a calcified granuloma, basically.
I see.
What makes you
Okay.
say that? What are the bits that make you
So
say it?
I mean, the thing is that it was just so these lesions that you got in particularly within the right upper lobe, they're very spherical, soft tissue density. There's a few of them, 1, 2, 3. So it felt like there must be some sort of cavity or solid As in, with a cavity, you normally have like a fluid level or an air level, but this doesn't seem to have that, but it looks very, very spherical.
You mean
Like a
up
potentially soft
this
tissue
area
lesion.
up here? Yeah,
Yeah,
so
and then a bit
you've
further
got some
down.
soft tissue lesion exactly there.
Mm.
You've got a cavity up here. So if I then
Yeah.
take this away, it's always difficult with that first rib, eh? The first rib can really make you think you're seeing a cavity, but this is the inside of the first rib, whereas this is the edge of the cavity there.
Oh, okay.
So what are people saying? Is it active? Yes, says half. No, says a quarter. Can't say, says a third. Bilateral upper lobe fibrosis, right apical opacification, hyperinflation of the left lower zone. Somebody suggesting an aspergilloma in a TB cavity. Is this the aspergilloma you're thinking of, or it's not so easy to decide what this is? It's a sort of area of increased density. I would say on this film that it's not a super great quality film, so detail in the lung parenchyma is difficult, but you can definitely see hyperinflation. Somebody described right upper lobe, apical fibrotic changes with a hyperinflated left lung. Exactly. So the fibrotic changes are something that I wanted to highlight. He presents with progressive dyspnea, but no signs of active infection or inflammation. If you look, if I just bring that fading arrow back, this here is your lower lobe artery in the hilum. And you can see how it's completely pulled up. You've got your aortic arch here, the left hilum. This is your left hilum here. So both hilum are making their way up to the apex of the lungs. So these upper lobes are really contracted, atelectatic. There is that cavity there, but there is, I think, also a lot of old scarring, which is pulling up the hilar. The fibrotic changes, pulmonary sarcoid, somebody saying you can see upper lobe, exactly these kind of changes. The point here is that it's very difficult. All the findings point towards this could be old TB, but you have to be really correlated with the clinical presentation of a patient. So if all he's got is dyspnea, a non-productive cough, but no weight loss, and then his sputum is negative and he's otherwise fine, it's less likely, not always unlikely, Karen, but it's less likely that it's active disease, but you have to be very careful to call something old. What would be a really helpful thing if you're worried that it's old, or if you want to know if it's old?
Previous imaging, I guess.
Previous imaging, yeah. And so for this case, I had two images. I had one good quality and one not so great, and they are 5 years apart. This is the one from 5 years before, actually. So there are two images and they are identical. So in that case, that argues very strongly for old TB changes, lots of fibrotic changes, and absolutely true, Angst-Pond can cause this type of fibrosis as well. But with the less dense opacities, thanks. That is the kind of thing I'm not entirely au fait with, so thank you. New reaction test. What? I'm not sure what you mean by that. Mantu. Oh, I see. Yes, thanks. Yeah, exactly. But if somebody's had old TB, then that will be positive, won't it? So these are classic appearances of fibrotic changes of old TB. And again, there's been some really good differentials given, but be careful that you always correlate it with how the patient's doing. If the patient is not doing well, make sure that you rule out active TB. And for that, sometimes CT can be helpful. You'll see more of the active sort of endobronchial changes that you don't see on the X-ray. Okay, we've got 10 minutes. I think I will now no longer bore you with tuberculosis. Or maybe one more. But we're going into a very different part of the chest now with the next case. This is a 13-year-old child who presented with a dry cough, fatigue, and chest pain. And again, he is from, I can't exactly remember which sites, but again, from one of our sites in Africa, I think. And the question was dry cough, chest pain, is this tuberculosis? The left heart border is straight, rounded, large heart. Yes. Yeah, so we've got the left heart border is rounded here. Yeah. The heart is enlarged. It's a child. Mitral disease, enlarged shadow, splaying of carina. Exactly, you can see the carina splayed. Can you see this here, this contour? What does that make you think? Maybe the arrow faded too quickly. That contour there, can you see that edge along here? Double right heart border, double density, left atrial enlargement, exactly. So this is actually all left atrial enlargement, and this is the left atrial appendix, which this bulge here. So these are all signs that that left atrium is really big. There is some vascular congestion. I agree that there's a sort of fluffy outline here. You can see this. Whoop, that didn't quite work. This bronchus should be nice and pencil thin, but it's a bit fluffy there, isn't it? So there is definitely some vascular congestion. Venous, agreed. Maybe need an echo. Yes, that's, if possible, then that would be great. And yes, Dama has just come up with the diagnosis, rheumatic heart disease, rheumatic fever, exactly. Yeah, so these are the long-term sequelae of valvular disease secondary to rheumatic fever, that very big left atrium. And I didn't tell you, but the child had mitral and tricuspid murmurs, which I should have told you, but I didn't. So exactly, this is mitral valvular disease. Excellent, very good. So no signs of pulmonary tuberculosis or TB here. This is heart disease, sadly, due to rheumatic fever.
Wow.
Yeah, yeah, and you know what? I'm seeing engagement from my colleagues, which is great. I'm really pleased you've joined. It's not uncommon to see it. It's really 500,000 new cases each year still worldwide. So it's still really a common, and in children, it's the most common etiology for acquired heart disease. So again, if you're interested in this kind of work, and then you know these are the kind of things that you're going to come across and see. And I think maybe I've gone too fast now. I'll have to. The last one. Right, so we'll start. I mean, there might be somebody on the call who actually knew the final outcome. This is a patient who presented with weight loss, general malaise, and maybe shortness of breath, I would imagine. So I'll give people a chance to have a look. Subcarinal mass on CT, widening of the paratracheal stripe, right paratracheal. Yeah. Okay, so absolutely right. So we've been talking about that paratracheal stripe where you would expect the right upper lobe, the lung, the air to sit right up against, but you've got this very big, smoothly outlined soft tissue mass here, which is right paratracheal lymphadenopathy. Yep. narrowing of the left main bronchus, well spotted here. Yeah, very narrow left main bronchus. Mediastinal lymphadenopathy. Yeah, so the heart, the aortic arches are in here. So this bulge here is actually the aortopulmonary window that you're seeing. So there's also lymphadenopathy, soft tissue in the aortopulmonary window here. Subcarinal is a bit harder on a chest x-ray. It's quite dense under here, and you've got that narrowing there. Sarcoid, yeah, excellent thought. Not much of a parenchymal problem, agreed. Some form of a malignancy in a patient with a secondary opportunistic infection, immunosuppression, some form of malignancy, lymphoma. Lymphoma is a very good thought. So we've got sarcoid, TB, lymphoma. Those are absolutely the ones. Interesting, lymphoma. So this is the conundrum. This is exactly the situation. Now imagine, so what I wanted to highlight in this case is that if this patient was able to have a CT, but say you're in a place where they can't have a CT or they can't afford it, they might live next door, but they can't actually afford the CT. And again, there are several people in the audience who are well aware, who work in this situation. If you're in a context where TB is common, it might be the only thing that you can actually treat. So I think one of the lessons for me when I started working in, I come from a place, I trained in the Netherlands where we can do everything and we can get all the diagnoses, all the tests we want basically. But I had to really learn to come off the fence and just say, okay, given the local situation, the epidemiology, the prevalence, and what we can treat here, it might be lymphoma, which where at that time where I was, you couldn't treat. It might be sarcoid. We don't really know that. Yes, you could, an endobronchial biopsy, exactly that would be great if you have that opportunity. If you can do that, then obviously, if you're not sure, you would do that. You would do an EBUS. But if you can't, then the value of x-rays really goes up. It's the only thing you might have. You've got to come off the fence and you're going to have to say, okay, given where I am, I'm going to put TB at the top. The patient's not HIV positive, not immunocompromised. I'll put lymphoma next. Can't treat anyway. Sarcoid, you wouldn't treat. So just you try and treat. Karen, prior to getting your support, Karen is at our Gambian site. Thanks for joining, Karen. We would have treated everyone with this kind of appearance with TB. No access to diagnostics or treatment for malignancy. Exactly my point. Yeah. So you just go on what you can do. Yeah. So this patient went on to have a CT. It's actually one of your patients, Karen. And sorry, I should have stayed where I was, shouldn't I? And I think this is probably the most engaging. Oh gosh, I've got 1 minute. So you will have been able to scroll and you will have seen.
Don't worry, it's not a hard cutoff.
Oh, it's not a hard end. Okay,
no,
great.
No, it doesn't blank off at
okay.
that time.
Yeah, I was trying to fill the time and now I've overrun. So you can see this huge big lymph nodes here, subcarinal, low attenuation node, left hilar nodes, not so much in the right hilum. And if you scroll through, you'll see that these, for example, here, oh gosh, and I've got to do my pencil again, haven't I? Can you see that there are sort of areas of enhancement and necrosis? So these are necrotic nodes. The fat in the mediastinum is all grey and sort of affected. If I go up to the pulmonary window here, you can see there are nodes in there. Now, sarcoid can give you necrotic nodes, but it's much more uncommon than TB to do that. It's usually they're not necrotic in sarcoid. They can do it, but it's uncommon. Lymphoma can do it, but just on statistics and the context, TB is the most likely explanation here. There were no lung changes. The lungs are normal here. The smooth narrowing of the bronchus can sometimes tip you a bit towards TB. But this is a demonstration of how sometimes chest X-ray is all you've got, and you really have to try and get off the fence and do the best you can with it. So that I think is the last case. Thank you, and thanks for joining.
Thank you so much. I really think that was very beneficial for so much of us, and I think it's also important to be aware of the work that you do. So if you are interested, do see if there's any way you can help. And I think stuff like this does remind us like how privileged some of us can be with the amount of imaging and diagnostics that we have available. You don't have to look too far to understand that some people don't have anything remotely close to even a chest X-ray. So yeah, it's really humbling and very, very interesting cases as well. So honestly, thank you, Liz, for doing that. I really appreciate it. So from my point of view, thank you. I'm going to hand over to Danish just to finish things off. But I'm sure everyone would love to have you back. I'm sure of it, because the case has been absolutely brilliant. So thank you so much.
Well, thanks for giving me the opportunity. It's been great. And thanks for the engagement from the audience. I'm sad I can't see you, but it's nice that, to get the engagement. Thank you.
Thank you so much, Dr. Liz Joekes. Slightly different take on chest imaging and infectious disease, but a great interactive session, which I hope you've all found valuable. I'm just going to go send the survey in the chat now, so please do fill that in to get your CPD certificate. And we will see you next month on the next webinar. Thank you, guys.
Thank you.